Welcome to the Cardiology Lecture for the Paramedic Prep course. My name is Nathan Klein, and we'll be taking a look at the cardiovascular system today. This system that moves blood to and from our tissues is vital to the continued function of all other systems in our body. It is because of this that we should have a thorough understanding of the inner workings so that we can manage and treat patients who are having cardiovascular emergencies. We will start with the anatomy of the heart. Here we have the right atrium. This is one of two upper chambers of the heart and is where blood first returns from the vena cava and the tissues of the body. From this chamber, the heart will contract, pushing blood through a one-way valve called the tricuspid valve. Valves play an important role throughout the heart in keeping blood heading in one direction. The tricuspid valve lets the blood flow down into the right ventricle. The right ventricle is the smaller of the two lower chambers. Its job is to pump blood into the lungs to exchange oxygen with carbon dioxide. The path to the lung is hard to see here, but it leads through the back of the heart to the pulmonary artery. The pulmonary artery is the vessel that carries the deoxygenated blood to the lungs for gas exchange. As we learned in pathophysiology, the high concentration of gases across the semi-permeable membrane leads to the equalization of gases in the capillaries of the lungs, with that of the gases in the alveoli. It should also be noted that this vessel is the only artery in the body to carry deoxygenated blood. Let's turn this heart around and take a look at where the blood goes when it returns to the heart. You can see that the other side of the heart has an upper and lower chamber as well. This upper chamber is aptly called the left atrium. The upper chamber receives blood from the pulmonary vein, returning from oxygenation in the lungs. I also want to point out that this vein is the only vein in the body that carries oxygenated blood. The blood is subsequently pushed through the mitral valve, or as it's also called, the bicuspid valve. This valve is so named for its vague resemblance to a bishop's hat, called a mitre. It is also known as the bicuspid valve in contrast to its right-sided neighbor, as it only has two lobes in the opening. As the blood moves through the valve, it enters the left ventricle. This is the part of the heart responsible for pushing blood to the extremities of the body. It is therefore the largest of the two chambers. With each contraction, the blood is pushed upward and out through the aortic valve and into the aorta. The aorta is the largest of the arterial vessels, and it's where the blood journey begins on its way to the rest of the body. I should point out that the cardiac arteries branch off at this point so that the heart gets first dibs on the freshly oxygenated blood. The blood moves through the vessels to the capillaries in the tissue where the oxygen will be exchanged for carbon dioxide before returning to the heart once again. Next, I want to look at the electrical system that powers this workhorse of a pump. With the rest of the body counting on an uninterrupted flow of blood, you can imagine that the heart needs to be resilient in its design. Thankfully, its electrical system has multiple layers of redundancy built in case of failure. Under normal circumstances, the heart's electrical generation begins with a single node called the sinoatrial node. This part of the heart sets the pace for the rest of the cells. When a cell receives the electrical charge from the SA node depolarizing, it causes a chain reaction of depolarization, which in turn causes muscle contraction. Because the SA node is located in the atrium, the two upper chambers contract, first pushing blood into the lower chamber. The SA node's natural state of depolarization is between 60 and 100 times a second. This can be increased in times of increased oxygen demand. The electricity flows from cell to cell until it reaches the atrioventricular node. Here, the electricity is slowed down at the AV junction in order to allow the blood from the atrium to pour into the ventricles. The AV node can also take over the task of pacemaking in the case the SA node is damaged and fails to discharge. The AV junction channels the electricity through the middle of the heart and into the bundle branches. Here, the electricity splits off into two channels that run down around the bottom of the ventricles before working their way up to the outside of the ventricles. In the event that both the SA node and AV node are blocked or damaged for some reason, the bundle branches can provide an initial discharge, but only at a rate of 20 to 40 beats inherently. The final part of the cardiac conduction pathway is the Purkinje fibers. These spread the electrical signal across the ventricles on both sides. If the rest of the heart's conduction circuit is not functioning, then even the Purkinje fibers can depolarize autonomously. Much like the bundle branches, the inherent rate of this section is only 20 to 40 beats per minute and will not usually be sufficient for long-term perfusion. Now that we understand the basics of the cardiac conduction pathway, let's look at how this conduction is manifested in an electrocardiogram. Scientists since the 1870s have been able to monitor the electrical amplitude of the cardiac system. It wasn't until 1895 when Wilhelm Einthoven introduced the method of identifying each element of a cardiac depolarization cycle as illustrated in an ECG. The sections are labeled P, Q, R, S, T, and movement above the central isometric line is caused by positive electrical signals, while movement below the isometric line denotes negative electrical signals. Another way of thinking of that is positive signal deflection are signals moving toward the positive lead of the ECG, while negative signals are moving away. The P wave is the first part of the cardiac cycle, and it is characterized by a small positive deflection. This represents the atrial contraction. It should be uniform from beat to beat, though remember that any interference with the collection of the ECG can cause inaccurate deflections or noise to occur. The space between the P wave and the start of the QRS is also called the PR interval. This is where the electrical current is delayed in the AV node to allow blood from the atrium to the ventricles. This delay should not be longer than between 0.12 and 0.2 milliseconds in length. The large spike in our complex denotes the contraction of the ventricles. This large up and down motion is identified as a QRS complex. It should not take up longer than 0.12 seconds to finish. The longer duration can indicate damage to the bundle branches or that the origin of the beat is in the ventricles itself. The last part of the ECG is the ST segment and T wave. Elevation of the ST segment above the isometric line can be an indication of myocardial infarction. The T wave itself is generated by repolarization of the ventricles. The atrium has a similar wave, but is hidden in the QRS and therefore cannot be seen without specialized equipment. The T wave should be upright and generally rounded. Abnormally peaked T waves can be indicative of hyperkalemia, and an inverted T wave can represent damage to the heart. Now that you have a basic understanding of the ECG rhythm, I want to demonstrate the fundamentals of ECG interpretation. To start, we have to consider the baseline rhythm, the normal sinus rhythm. We first assess the rate, which for normal sinus is between 60 and 100 beats per minute. You can do this by counting the number of complexes in a 6-second strip and multiplying that by 10. There are a number of different ways to calculate the rate. some of which are more or less accurate for different kinds of rhythms. We next want to look at the regularity of the complexes. Do they occur on a regular basis, or are they variable? We may also see a pattern in its variability. For normal sinus rhythm, we should have a regular frequency of beats. P-wave evaluation is the next step. We should see a P-wave before each QRS, and it should be upright. We also want to measure the PR interval, as we have discussed earlier. The QRS should be normal with its down, up, down motion, and no more than 0.12 seconds in duration. With these evaluations, we should be able to determine the rhythm that we are looking at is in fact normal sinus rhythm. It's also this methodology that we will use to evaluate all rhythms as they come across. There are a lot of variations in general shape of a rhythm, but if you can stick to these characteristics, you can identify all of them. Before we look at another rhythm, I want to talk about one of the several ectopic beats that you might find in rhythms that you are evaluating. The most common of these is the premature ventricular contraction. This is when the ventricles fire out of sequence to the normal SA node. This can be due to irritation to the myocardium or ischemia. Here we can see two such contractions. Notice how they happen irregularly. They also lack any P wave, and therefore have no PR interval. Their QRS is large and longer than 0.12 seconds. The shape of the complex is also different from the normal beats we see alongside it. The premature ventricular contraction originates from the ventricle, so it has a larger QRS complex. So let's look at a very different kind of rhythm which you might see in the field. This one is called atrial fibrillation. Unless controlled with medication, atrial fibrillation can have a ventricle rate of 100 to 175 beats per minute. The atrial rate is much higher, and as you can guess from the two different rates, this rhythm is irregularly irregular. There is no pattern to the interval of the beats. The P wave that we can see are inconsistent in shape and can even be absent in some ECGs. There is no discernible PR interval, but you can see that the QRS is narrow and normally shaped. This tells us that the problem with the atrial fibrillation is likely caused in the atrium and not the ventricles. Now we can look at a very bizarre rhythm, and one that we as paramedics and EMTs are able to correct with timely intervention. We, of course, are talking about ventricular tachycardia. This rhythm runs in the 100 to 150 beats per minute range, though they can exceed that as well. This rhythm is regular in its interval. Normally, this rhythm has no P wave, but if they're present, they are not associated with the QRS. Because of this, the rhythm has no PR interval. Finally, the QRS is wide, almost V-shaped. This rhythm is one of two shockable rhythms where the quick use of an AED or cardiac monitor with defibrillator can quickly correct this rhythm. This rhythm can produce a pulse, but it isn't very efficient at moving blood, so these patients will commonly have hypotension and show signs of cardiogenic shock. The last rhythm I'd like to look at is ventricular fibrillation. Similar to atrial fibrillation, where the top of the heart is not effectively contracting, in ventricular fibrillation, the ventricles are not contracting properly. With this rhythm, the rate is unorganized, and it can become hard to tell what is and isn't a complex. As with AFib, VFib is irregularly irregular. The P waves are absent, and there are no PR intervals to speak of. The QRS is also absent as it is truly not a sustainable rhythm. Thankfully, this rhythm is another example of a rhythm that can be corrected with timely defibrillation. I hope you enjoyed this presentation on cardiology and that you will find this information useful as you prepare for the paramedic program. Have a great day.